Sure. So the liver transplant process requires patients to complete several steps before they get to the point of waitlisting. So patients need to get a referral from their diagnosing provider to a specialized transplant center. Once they have that referral, they undergo a series of evaluation appointments where they meet with a surgeon, a hepatologist, a psychologist, a nutrition expert, a social worker. So there's lots of people involved in the process, all making sure that the person is a good candidate for liver transplantation. So once the patient has finished all of those appointments, they then proceed to a listing committee where those providers gather to discuss what they found during their evaluation appointments and then make a decision about whether or not the patient should be listed for transplant. So there's a lot that a patient has to do before they're even considered for a transplant. Because the process is so complex, if we know that patients aren't being listed, but we don't know anything about where in the process they dropped out, we can't really design interventions in order to help people complete the process and get transplanted. So that's why we thought it was important to look at referral and evaluation as opposed to listing. And the reason that people hadn't done that before is because that data is not systematically collected. So we've got really good data on patients who make it to the deceased donor waiting list because those patients are waiting for an organ. We know who they are. But for patients who have not made it to the list yet, we require some center-specific data to get there. So to look at this particular question in our population, we linked data from the Georgia Cancer Registry, who collects data on all incident cancer patients in the state of Georgia. And then we linked that to hospital data from the only two liver transplant centers in the state. So that's Emory and Piedmont. So with this data linkage, we were able to create a unique cohort of patients who got diagnosed with hepatocellular carcinoma, and then we followed them through the referral and evaluation process at either hospital that they attended in the state. One thing that we were surprised by in our findings is that even though we really looked at early stage hepatocellular carcinoma patients who we thought would be good transplant candidates, only 1 in 4 of these patients were ever referred to one of the transplant centers in the state. And liver transplantation is the preferred treatment option in terms of survival and disease-free survival, especially for these patients. So we were surprised by how underutilized this referral was. In terms of other main findings, one thing that we found was that the factors that were associated with completion really varied by each step. So at the referral phase, we found that increasing age and having an insurance type other than private insurance was associated with not getting a referral from your diagnosing provider to a transplant center. But once you got that referral, we found that the neighborhood socioeconomic status of where a patient lived and their race was associated with whether or not they actually initiated the evaluation, which means that they attended an appointment at the transplant center. And after patients initiated the evaluation, we found that patients who had Medicaid were less than half as likely as patients who had private insurance to actually complete all of the evaluation requirements. One of the major limitations of this paper is that we are limited to only data from the state of Georgia, and so patients might have gone outside of the state to receive transplant care. One thing that's changing in the transplant research landscape is that there will be a new contract for the organ procurement and transplantation network. Essentially, what this means is as part of that contract, transplant centers will be required to submit referral and evaluation data nationwide. And so that will enable us to look not just at variation in the process, but variation across centers. So we can identify some center best practices and who's getting patients through most efficiently. One of the main things that I think will be important and that we have learned from our findings is that referral is really underutilized. And we think that referring providers might have some different ideas about what makes a transplant candidate eligible as opposed to what the transplant center thinks. So, for example, at the two transplant centers that we looked at, any insurance type was accepted at the transplant center, but still patients with private insurance were much more likely to be referred. And we're worried that that might be because referring providers aren't aware that other types of insurance are accepted at the transplant center. So some education on the referral side would be really important to increase the number of referrals. We think it'll be important to take a look at barriers for patients who are either not initiating the evaluation or who have initiated it and are having trouble completing it, to understand how we can streamline the process for patients, potentially using things like telehealth appointments to reduce the burden on the patient.